Start recording. Okay.
Timer. Right, ready when you are.
All right. Welcome to the Nervous Breakdown channel. We take concepts about the nerves, the brain, and the spine and break them down to language you can understand. We explain jargon and simplify medicalese. I'm Dr. Estrada Bernard. I'm a board-certified neurosurgeon. And
Dr. Christopher Gay, board certified in anesthesiology and pain management.
so today we're going to talk about how do you deal with low back pain? Let's say you were moving the dresser and you develop this sudden pain down your leg from your low back. You go to see your primary care doctor and they say you have a serious problem and we need to send you to a specialist. So we both take care of people with low back pain and have referred patients to us. And so we're going to give you the perspective from two specialists who deal with this problem all the time.
Absolutely. So, and we're going to talk about what's going to happen. What can you expect? You're going to get some imaging. You're going to get surgery. You don't know. You just want your life back. So, you just gotten the diagnosis. You've gone to the doctor and they sent you for imaging and they said you either need to see pain or you need to see the brain. So, let's say you go see the brain, the spine surgeon in this case, or I got a neurosurgeon, Dr. Bernard. So, oh, my back. You're walking in the office and Dr. Bernard, my primary care doctor just sent me here. I've got this pain in my back and it shoots down my leg. I can't sleep. I can't walk. I can't do anything. How are you going to fix me?
So first of all, I think there's a misconception that people feel like as soon as they get an issue that they should have an MRI scan of their back. Now, there have been studies that show that 60% of people who've developed back pain, well, let me back up. 60% of people who are normal without any symptoms, just walking down the street, nothing going on. If you do an MRI scan on them, you're going to find herniated disc, you're going to find spurs. And so it's very important to be able to make the clinical correlation. So the first step is generally not to do the imaging, not to do a CT scan, not to do an MRI scan. You want to get an evaluation to make sure, one, you're not having any serious nerve problems that need immediate attention. If you
Doctor, I
don't,
got a nerve problem. It hurts. That's my nerve problem. It needs immediate
okay,
attention.
that's great. So now so what is the solution? So we don't want to jump into surgery. So sometimes people come to me and they say, oh, well, the doctor referred me to have surgery. But we know that 80% of people who have a new onset of a ruptured disc in the back will have resolution without surgery. So if you're going to most likely get better without surgery, there's no need to have surgery. So the first step is physical therapy, non-conservative treatment such as that.
How long does that take? I hurt right now. I need this pain gone yesterday. I got a
Excellent.
vacation already booked my cruise for next week.
Yes, it used to be that people would recommend that you go to bed rest, but it's been found that is counterproductive. You need to be active. Now you need to take medication. If you're having a lot of pain, medications, Tylenol, non-steroidal anti-inflammatory medications like that can help. But if with movement and with medications, you're not making headway, your quality of life is significantly impaired, you can't sleep, you can't work, then sending them to a specialist like Dr. Gay is going to be the next step to try to get things to settle down. So Dr. Gay, I see this patient, I put them on medications, it's not working. I get them started on physical therapy, but they're hurting so much they can't even get physical therapy started. How can you help this person?
You've come to the right place. The house of pain, we try to get rid of it and make it go away. So there are a number of things that we do. There's quick fixes and there's long-term fixes, right? And so physical therapy, those things are great. They're going to help repair all the things that have gone wrong that have led to this. So maybe the muscles aren't supporting your back. The disc is now pressing on the nerve. It hopefully lift that off some, but it takes a while. You hurt right now. You want to get rid of it. So we have this thing, you know, anti-inflammatories. You usually try those over the counter or prescription, and they're all non-steroidal anti-inflammatory drugs or NSAIDs. We've got, I call them SEDs, the steroids, the steroidal anti-inflammatory drugs, and they're very, very, very strong anti-inflammatories. And I describe this as like a fire that we're trying to put out. Inflammation is just, you know, irritation around the nerve, and it's like having a fire in your house. Number of ways you can treat it. You can put water on it. You can get a water hose. You can hope it rains, and that may help. And sometimes we'll use an oral steroid, which is a pill that you can take. Goes all throughout your body though. So that's like dumping rain on the whole neighborhood when your house is on fire. It may help some, but it may not do the trick. Sometimes we have to get right in there where the problem is, and that's where the injections come in. And people say, oh, it's a shot. I've heard of epidurals, but I'm not pregnant. It's a very different type of epidural, because the epidural space is, it's a location in the body. What you put in it is what makes the difference. You have a baby, we put local anesthetic. It numbs things. You don't feel the pain so much.
So Dr. Gay, epidural, where is that? When you say epidural, like we hear that expression a lot, and sometimes people don't know what does that mean,
sure,
epidural.
sure.
So women may be more familiar, but there are a lot of guys
Absolutely.
out there who have no idea what that means.
Very, very, very good point. And I always tell patients that, hey, even though we're going to do an epidural, you're not going home with the baby after this. And so it is a space that runs from basically the low back, the tailbone, all the way up to the base of your spine. And it is where we'll say the nourishment for the nerves and things, that it sits in that space. So you can put medication there and it'll diffuse over to the nerves, and it'll usually help numb them when, in the case of a local anesthetic like lidocaine that you might get at the dentist. You put something similar to that in when you have a baby. In this case, that nerve is irritated, and we want to calm that down. So we'll put something to calm down that irritation. And if I were a fireman, I'd put water. Not a fireman, so I'll put a steroid usually. And then a steroid calms out inflammation over a number of days. For most people, usually about 3 to 5 days for that to kick in and start working, and then about a week to get to its full effect. So 2 weeks is kind of where we pass judgment of whether this helped a lot or didn't help at all, and we need to look to something else. And so
I have a spine model, and I was going to show. So this, if this represents the spine, and the spinal cord is covered by a substance called a dura. And so what Dr. Gay is talking about is he'll stick a needle in between the opening within the back of the spine, and put that medicine, the steroid, into the epidural space. That is the space on top of the dura to calm down the nerves. And you can see here, this is an example of a nerve coming out of the spine, but that medication coats the nerves, right, Dr. Gay, and helps it to settle down.
Yeah, and most people get scared. So just so you know, my needle's nowhere near as large as that pen that he just had. We actually use a very, very, very small one to numb the skin first. It's about
a small needle.
Yeah, it's a small little pinch and burn, like a little mosquito bite. It's about as thick as a piece of hair, and we numb the skin with that, and then we numb deeper down. So after that, you really just feel pressure. We're pressing on things, and once we get to where we need to be, we do it under X-ray guidance, and so we can see exactly where a needle's going at all times. We don't use the force. We know exactly where we're at. We inject a few things. We can see that it's spreading around the nerves, and if we're happy, we inject a steroid and we get it out. Whole thing takes about 5 minutes or less, and then people sometimes feel better right away. Now, we said sometimes people have the shot, they come back, they're not any better. Things may even be getting worse in the case where they're having weakness in their leg or other things where you can't control your urine and bowel movements and things like that. We call those surgical emergencies. And so then we're out of the pain game. We're sending you back down to see the neurosurgeon. So now they're back over to see you, Dr. Bernard. What are we looking at in terms of surgery?
Well, so important point. If non-surgical treatment isn't working, then the question is, how long can you manage to give it time? Because eventually, within 6 months to a year, most of it settles down, but you may not be able to afford to be out of work for 6 months, or you may not be able to tolerate it because you can't sleep, in which case you would need to have surgery. Now, in other situations, there's so much pressure or so much inflammation on the nerve that the nerve begins to lose function, and you may develop weakness. And if you're starting to develop weakness, then that may be a sign that it may not be a good idea to continue to wait, because then you run the risk of getting permanent damage and losing function.
How long is that? They say good things come to those who wait, but not to those who wait too late. So
Yes,
when
that's
is it
right.
too late? Once they have
Yes.
those signs, when do they need to treat it by?
Well, it all depends. Now, if it's a mild weakness, then you can do it electively. That means you can schedule it. Now, if someone has a complete functional loss, like they can't lift their foot up anymore, their foot is flopping when they're walking, we consider that a medical emergency, and you need to get that addressed within 24 hours. Similarly, if you have enough pressure on the nerves that go to supply the bladder and the bowels, and you're starting to lose bladder and bowel function, that is a surgical emergency. We don't even wait to get that scheduled electively. We would have you come straight to the emergency room and have you ready for surgery right away. So,
Now,
but that's a wrap for, we're at almost 11 minutes now, so we'll stop here and see where we are.
so well, let's give some good take-home points. So if you have, we talked about surgical emergencies. So if you have back pain shooting down your leg and it leads to severe weakness where you can't walk, can't hold in urinary bowel movements and those issues, or those you want to go right away. Don't go to your primary care. Don't even go to the urgent care. Just go to the emergency room. Other things they can wait, and we have conservative options that may work pretty quickly. Things that may take more time, and then we have our friendly neighborhood surgeon. So hopefully you don't have to see either one of us anytime soon.
Yes.
All right.
Well, that concludes this episode of Nervous Breakdown, and stay tuned for the next episode where we will delve further into how you can understand these medical concepts about the brain, the spine, and the nerves in simple language that you can understand.
Nervousbreakdown.ai. We'll see you there.
Okay. All right.